Now, the bite in the jaws is a fascinating subject, especially if you're a dentist. But for the purposes of this, we're talking purely about the relationship of the teeth and the bite as it relates to wearing an oral appliance. As you know, an oral appliance doesn't necessarily pull you forwards, but it does hold your lower jaw in a position where it won't fall back. So that when you put your head back, your jaw, which is attached to your tongue, of course, or tongue's attached to your jaw, depending on which way you look at it, as your jaw would normally fall back with gravity, it's held by the appliance from doing that. So that way, because your tongue's within your lower jaw, and the back of the tongue is the front of the airway, it keeps the airway patent. So that's a good thing, but it does mean that you can't let your jaw fall back. And that is a good thing, except that, and this is not a good thing, except that generally speaking, and this is not normal, it's just that it's very commonly seen, the lower jaw is too far back. Now, in actual fact, that actually predisposes the person to obstructive sleep apnea. And so one of the questions that dentist or even a well-informed doctor will ask is, or not only ask but look for, is that lower jaw short? Is there an increase in the overjet? So in other words, is this lower jaw further back than it should be? And of course, everything from normal growth to a compromised airway during childhood, right the way through to adjusting fillings and taking the bite with the patient laying back, which of course is not how you're going to spend the rest of the day. All of those things tend to put the jaw in a further back position. Okay, so that's not ideal, and the reason it's not ideal is because if you think of the teeth and you think of the bite, it's attached to your lower jaw, and your lower jaw is attached to the joint. So if your lower jaw is further back, the joint is further back, and if the joint is further back, it's more compressed. And there's a lot of very sensitive, called retrodiscal tissue back here, which has got a lot of blood vessels and nerves. So we've got the lower jaw sitting like, this is the lower jaw, the lower jaw sitting like this, and normally it would be here. However, when the lower jaw is further back, obviously you get more compression in this area. So along comes your friendly dentist, makes you an oral appliance, which works really well because it holds the airway open, because it's holding the jaw from falling back. So far, so good. The problem is that this gets filled with fluid then during the night, so the 6-7 hours that you're asleep, and then when you get up, it's further forwards than it normally is, which joint-wise is great, but when you close your teeth together, the teeth don't close the same way they did the night before. Now, because it's only fluid, normally only fluid, after a relatively short period of time, maybe half an hour to an hour, that fluid is dissipated because the teeth and muscles are pulling the jaw up, and so the teeth close and find their normal position, and that compresses the joint again, pushing the fluid out. So you're back to square one. And that's how the majority of people experience this. They'll have a strange sensation of teeth not closing properly when they get up, and then after a relatively short period of time, they're back to square one. Great. The next thing is those people where the jaw comes down, which is a good thing, but it feels more comfortable. What those people will notice as time goes on, and this is not tooth movement, this is jaw movement, but as time goes on, they'll notice a slight lack of contact at the back. They may notice a bit of a contact at the front, and although there's no studies done to show this, if you think about it, it does make a lot of sense that for those people that are more compressed when they come in and have the oral appliance made, then they're going to be the ones that will be decompressed more during the night. So that's a good thing. And the general direction is for, because of this on a constant basis, night after night, the general history of the way this goes is that the lower jaw will move down and forwards. So that's why people who have an increased overjet this way, as time goes on, it will get better. On the other hand, for people who have an edge-to-edge bite, or what's sometimes called a negative overjet, more of a very prominent lower jaw, that may very well worsen to the point where you get, as I say, a negative overjet. So the ideal person is someone who has a slightly to increased overjet. Now, following that argument, there are some people who are who find that during the night they come forwards, everything's fine, but because that's a more optimal position, the jaw then thinks, well, the jaw doesn't think, but the patient feels much more comfortable, and then automatically, without the patient doing anything, all the muscles relax, the fluid comes back in, and they really can't, or sometimes just simply don't feel very comfortable in going back. Sometimes people get up in the morning and say, do you know, I actually feel better in the morning than I did when I went to bed. And that's because of that decompression of this very sensitive tissue. Now, the reason we don't treat everybody and say, well, that's great, let's kind of fix them up so that they're okay during the day, same position at night as at night, is because it's a lot more treatment. And really the best treatment that you can get by with and ensure comfort and function is the treatment that is that's indicated. So what we're really looking at doing is doing only what's necessary. So there are, I would say, 90% of people who simply notice that during the day, in the morning when they get up, their teeth don't close together the same way, and after a relatively short period of time, especially after eating breakfast, when you've had the sort of muscles going, it recompresses the tissue behind the joint, and the teeth close and everything's great. There are some people who over time will develop a very, very slight open bite on the back teeth. That's a known fact, and it can happen after a couple of years or even 6 months, or it's a known problem which people very rarely notice. In fact, they did do a study on it. They found that the majority of people didn't actually notice they had it. But nonetheless, we always tell people just so that they don't worry about it if it happens to them. There are, however, a very few, and I'm guessing I would say a couple of percent of people who fall into the last category, where the decompression is really comfortable. It's an optimal position now. The muscles are comfortable, everything's great. The only thing is the teeth don't line up. But they don't line up in a forwards to backwards position, and all that happens is you develop a more pronounced open bite at the back. Now when I say develop, this is the jaw, not the teeth. The teeth don't move per se, although a lot of dentists are sort of concentrating on tooth movement. Well, what we've got here is more of a jaw movement, of a jaw moving forwards, being decompressed because it's more comfortable, and finding that there's a slight difference in the bite. That bite change then will leave a small space at the back over the molars. So what we do then is we make a small appliance which basically acts as an overlay to fill in that space. So when the person is closing their teeth, as far as their jaw is concerned, then they're closing and they're biting in this optimal position. And a lot of people will optionally request that position simply because it feels so much more comfortable. Don't have to do it, but those very, very few people for whom this happens, they have a choice. You don't have to do anything, but a lot of them will feel a lot more comfortable. And so when you're chewing like this, by filling the back space in, you get a nice solid bite and you don't decompress the joint. Obviously, if you were not to wear that, you would still get that joint compression during the day, but then it would be decompressed at night because you got the appliance holding you down and forwards. So the summary of all that is most people, when they wear their oral appliance, they put it in, brush their teeth, put it in, everything's great, good night's sleep, get up in the morning, bite feels a bit different in that it touches at the front more than the back. After a relatively short period of time, that's all gone back to normal, especially after chewing for breakfast. Some dentists suggest bite exercises. Sometimes they'll use what's called an exerciser, where you just sort of bite into it. Piece of toast probably just works as well. And also positioners can be used. And a positioner tries to duplicate the position where the teeth were before. But of course, the issue here is that it isn't tooth movement, it's jaw movement. And I think that we as a profession need to kind of recognize that, because at this point in time, all the books talk about tooth movement, and that's not what this is. So that's the majority of people. There are some people who will develop, there's always a degree of tooth and bite change, always, but that's okay, because the benefits are so great, outweighs the disadvantages. But there will be always a little bit of a change, and some people will notice that as a inability to eat lettuce sandwiches. That's about what it boils down to. Those people, probably you would just say how you feel, and they say just can't eat lettuce sandwiches. Apart from that, it's not really a big deal. You could have treatment, but that's overkill. For those people, however, who feel much more comfortable and have gone much further down, and it's a very much more noticeable position change, then a small overlay over the back teeth works brilliantly. Long term, if they feel that that's an ideal position, you can actually have onlays built up over the teeth, especially if you've got, well, there are people who have crowns or big fillings. They're an ideal candidate because this way it protects the teeth anyway. Or there are people who have untouched teeth, and you may even want to consider orthodontics. You've got to find somebody who knows what they're doing, but nonetheless, that is an option. So those are the three main things. For people who are interested, we've got some really good printouts from studies that have been done by very well-known clinicians in universities, and so that they're peer-reviewed, so it's not just someone's opinion. But it's an interesting subject, and it's basically something that affects everybody to a degree, but not to the point where it makes it's not a difference between success and failure. It's just simply that people notice it, and if you don't know what to expect, then you could worry. But as always, if there's any concerns, then you would call me or the office, or for anybody who's watching this that's not in the area, then or has another dentist, then you would ask your dentist. But it's nothing to worry about. So that's about it. Thank you very much for listening, and we'll do another topic next time.